All right, well, let's get started, everybody. Thank you for joining us today. My name is Stephanie Reefy. I am the Senior Director of Patient Advocacy and Alliances at Exact Sciences. We are very excited to have a program for you today about our molecular residual disease test called Oncodetect, and more information about the science behind that test and how it can be used. You probably noticed we're having a little bit of technical difficulty with one of our speakers, but we are hoping that you will hear from both Dr. Christy Russell, our Vice President of Medical Affairs at Exact Sciences, who will talk about the science behind MRD testing, and then Trevor Maxwell, who is the founder of Man Up to Cancer and a stage 4 colorectal cancer survivor who has used MRD testing in his own treatment journey. He will provide the patient perspective. Before we get started, I also want to introduce you to Tawanna Williams, who will be joining us a little bit later on screen. She is our lead patient advocacy manager, and she has coordinated this event for us. You've probably heard from her on several occasions. And I want to let you know that we are recording this webinar and will be making it available once it's been approved for distribution. As you've probably noticed, you as the audience are not on camera and you've been muted, but please use the Q&A to ask questions along the way, and we will be fielding those as time allows. With that, I will bring Christy on screen and we'll get started. Hi, Christy.
Hi, everyone. I appreciate the opportunity to do this presentation, and there's already a question in the chat around MRD and what that means, and so as Stephanie is bringing up the slides, I'm hoping. So for hematologic malignancies, myeloma, CML, that was the original wording of MRD, which was minimal residual disease. The correct terminology, although physicians mess this up continuously, is molecular residual disease refers to circulating tumor DNA from solid tumors. So that's the difference between molecular residual disease and minimal residual disease, but physicians frequently interchange these. All right. Thanks, Stephanie. Okay, so everybody be aware that I am Vice President of Medical Affairs at Exact Sciences. Thus, you don't need to read all this. I have a significant conflict of interest and a bias. I love all Exact products, and so I will speak positively to Exact products, but at the end through Q&A, happy to answer any questions at all regarding the product. And next slide, please. All right, this is a company who has a mission, and the mission includes offering solutions to patients before, during, and after a cancer diagnosis. And there are many products that Exact Sciences has commercialized. And this is just a summary of what many of them are that either are nearing commercialization or are commercialized, and many more to come that are not on this list. But just quickly, RiskGuard that's on your left is for germline testing of cancers or hereditary cancer testing. In terms of other products that are available for screening and surveillance, Cologuard or Cologuard Plus are likely names that you're familiar with. For colon cancer screening, Oncoguard Liver for screening or surveillance for liver cancer. CancerGuard is our multi-cancer early detection test, now on the market for generalized multi-cancer screening. And then for those patients who have cancers, that's where the orange sits there on this slide. Our most well-known product is Oncotype DX for invasive breast cancer. trying to make decisions in women with early breast cancer, whether they would benefit from chemotherapy. Oncodetect is what we'll be talking about today, our MRD product. And then on the far right, OncoExtra, which is our whole exome, whole transcriptome, comprehensive genomic profiling for patients with advanced cancer to understand whether there's a targeted therapy that may work against their cancer. Today, we're going to talk about Oncodetect. And next slide, please. All right, what is molecular residual disease? So I'll speak to this slide, but I'm going to be more broad. We shed DNA into our bloodstream continuously. Most of that DNA, which is called circulating free DNA, means that it's native DNA circulating with not in the nucleus of a cell, not within a cell itself, but circulating, but came from a cell. And in our blood, we have so much stuff circulating, which is our normal blood products, white blood cells, red blood cells, and platelets. And that's a very dynamic factory. When you make a white blood cell in your bone marrow, it only lasts 4 to 8 hours and our body clears it. And as those white cells are breaking down, it releases that DNA into the bloodstream. And then after a couple hours, it clears. And it's true for all the blood products that we make from our bone marrow. So there's a massive amount of DNA that's circulating in the bloodstream. Well, cancer cells, as they're breaking down, also will release their DNA into the bloodstream. And even if you think about, well, why would cancer be breaking down? Because it's dying off for some reason, or we've treated it with therapy. But when any cell in our body grows, it's a dynamic of cells that are growing and cells that are dying off. It's just, if it's growing much more rapidly than cells are dying off. But cancer cells are always going to be dying off, even in a growing cancer. And so we have the ability to understand whether any of that massive amount of DNA circulating in the bloodstream is from us, or is it from the cancer? And that is what molecular residual disease, it stands for circulating tumor DNA in the bloodstream. So on the left-hand side is just a physical representation of that. On the right-hand side is, well, how do we detect it? And we detect it through the blood, but we have to, before we go to the blood, we have to understand what is the difference between the DNA from the cancer cells versus the normal cells. Now, when we draw blood, we spin it down. In the bottom, the heaviest cells are the red cells. You can see that's represented by red. On the very top is a little layer of white, which is called the buffy coat. That's where white cells reside. And in the middle, our plasma is our plasma, the kind of the yellowish clear portion of blood when it's spun down, and that's where the DNA resides. Okay, so next slide. So how do we get to this DNA? We get there through looking at the cancer. And we say, okay, we have the patient's cancer, and we take that cancer and we look at all the genes that are within that cancer. So we do right now what's called whole exome sequencing. We look at every gene and we look at the portion of the gene where proteins get made. That's called the exome. And we look at like how many gene abnormalities are sitting within that area of the exome. And we then judge the quality of those genetic abnormalities that some people will call variants. And we will test anywhere between 50 and 200 variants in a cancer. Now, those variants are not likely to be in our normal cells, but we also go test our normal white cells to say what variants are we seeing in our normal cells, and then we subtract them so that we're only looking for DNA that could be circulating that has these variants or genetic abnormalities that are only found in the cancer. We can then create a specialized blood test for that patient through probes. So we say, okay, this patient has 170 variants that are within their cancer or genetic abnormalities. And we will create a specialized blood test with 170 probes looking for any DNA that has those variants. The two will link, and we will know that there's that we are finding that is circulating tumor DNA. So it's very technical and complicated, but the bottom line here is for Oncodetect, our MRD test. This is specific to this patient and their cancer. It's not mixed up with anybody else's cancer, and it's not mixed up with your normal cell's DNA. Now, once we do this technology, we say, okay, where is this potentially useful for patients? So when a patient's diagnosed with their cancer and they have a surgery, for example, and at the end of surgery, one of the most common questions as a medical oncologist was, how do I know if the doctor got all the cancer? And we don't know. We do x-rays, we go looking for evidence that the cancer is spread to other parts of the body, and we don't see anything. And then we make a decision, well, based on the size of your cancer or its features or how abnormal it looks under the microscope, grade, or how many lymph nodes are involved, here is your risk that your cancer could come back. And so we recommend, based on that risk, that you should take adjuvant chemotherapy. But what if we had a test that said, okay, after surgery, there's no evidence of circulating tumor DNA or MRD negative, and do all those people need this adjuvant chemotherapy? So we have to prove that from clinical trials, but the promise is that after surgery, we would have a much better understanding of whether we've eradicated all the cancer with surgery or whether someone needs more therapy. So that is, do I still have cancer? Do I need further treatment? Let's say no matter what it finds, the patient undergoes adjuvant hormone therapy or chemotherapy. And then at the end of that therapy, we could do another MRD test and say, is there still evidence that there's circulating tumor DNA, or has it been eradicated? And then let's say it's negative at that point. So we'll now just follow the person with serial MRD testing to make sure that there's no evidence of relapse. Now, what we see is for someone who will recur, presumably with advanced cancer or metastatic cancer, that we start to see patients go from negative and begin to slide up with a positive ctDNA. At that point, we would do imaging. We could do a CAT scan or an MRI or a PET scan going to look for evidence that this cancer is back. And again, the MRD will be specific to that person's original cancer. And we know that MRD testing is so sensitive that we could find a positive MRD test up to 2 years before an X-ray ever turns positive. But there are studies that are ongoing right now to say, okay, let's say I turn positive, but the X-rays are negative. What do I do there? Do I start another therapy? Because the only thing we can follow now is the MRD, or do I wait for my X-ray to be positive? The promise of MRD is to try to get therapies into the body at the point where there's such minimal amounts of cancer that it's much more likely to be effective. But those decisions have to be made in shared decision-making between the patient and the physician. And then let's say we find evidence of metastatic cancer and we can find it on a scan of some kind. You could use MRD testing then to say, how is my cancer responding to treatment? And whether the MRD test is coming up and down will tell you how effective your current therapy is without waiting for a scan to be done every 3 to 6 months. You can imagine, I have advanced cancer, I can find it on an X-ray, I have an MRD test, I start a new therapy, but you're going to make me go through that therapy for 3 to 6 months before you're going to check the X-ray again. But we could find out much earlier with an MRD test whether that cancer is responding to that therapy. So it gives many different times over the course of a patient's experience with cancer. Hopefully it's all front-ended and they don't have recurrence, but to make decisions in a way with a much more sensitive test and much more personalized to that person and their cancer. Next slide, Stephanie. When we get a report, it's very simple report. Yes, the ctDNA is positive, and we know if it's positive, you're much more likely to recur, or no, the ctDNA is negative. It doesn't mean it couldn't turn positive later, but at least this period of time, you are much less likely to recur. We know that MRD is highly predictive of cancer recurrence, and we know that recurrence can be detected much earlier than standard physical examination or other blood tests or scans. Next slide. All right, so I just have some important concepts to talk you through regarding MRD. There are many companies now that have our MRD products on the market, but there are concepts around cancer and then the MRD testing that are important to know to say, do I have the best MRD test for my situation? Next slide, please. One is, there was a study that was done that looked at the presence of circulating tumor DNA or MRD across multiple tumor types. And this was a study of 640 patients of 14 different cancer types. But we learned from that the amount of ctDNA, or whether it's positive or negative, correlates with what kind of cancer it was, how much cancer was in the body, or for early cancers, what that patient's stage was. So next slide. So concept of shedding. Not every cancer sheds their DNA the same way. You would think, okay, if the cancer is dying off as it's growing, etc., or I put the patient on a therapy and it's dying off, they should shed their DNA. But not every cancer sheds their DNA equally. So if you look on the left-hand side of that left-sided bar graph, you would see that bladder, colorectal cancer, gastroesophageal cancers, ovarian cancers, big shedders. As their cells are dying off, they are pouring a lot of that DNA into the bloodstream. You can see on the right-hand side of that left-hand bar graph that thyroid cancer, not a very good shedder, or kidney cancer, renal cell cancer, not such a good shedder. So when we think about MRD testing, for cancers that are really good shedders, you're probably good with a test that might even be a first-generation MRD test that has excellent sensitivity, but not the highest sensitivity. On the other hand, cancers that are sort of on the right-hand side of that graph, it might be more prudent to use an MRD assay that has much greater sensitivity, or what we call limit of detection, in order to make sure if a negative is a negative, it's a true negative, and we're not showing any evidence of circulating tumor DNA. Because if it's not a very good shedder, it could be that there's cancer still in the body. We're just not able to see it through MRD testing. And the other concept on this slide is it matters how much cancer is in your body. So if you have a patient that has a stage 1 cancer and that is removed, especially if it's not a good shedder, then you're less likely to find a positive ctDNA, even if that patient hasn't yet been cured of their cancer. So we're sensitive to the type of cancer, and we're sensitive to what stage we're finding the patient, just recognizing that the amount of shedding, the ability to find the cancer, will be very different based on those two features. Next slide. So I'm just going to give you some examples where the sensitivity or this limit of detection of the MRD assay may matter. So there are high or moderate shedding tumors where If you have a negative MRD, it gives you much greater utility in saying it's highly likely this person doesn't have evidence of cancer on the body. But for low shedding tumors, it could compromise the ability to detect circulating tumor DNA in the blood, and thus all of the companies who have MRD products are in the development or have developed assays with much greater sensitivity so that we can reduce the rate of false negatives, a negative which actually isn't true for these low shedding tumors. Next slide. All right, so just some examples of high shedding tumors on the left-hand side. And these are cancer types where ctDNA is detectable in a large proportion of patients, but particularly in advanced stages. So you can see the whole list there: melanoma, big shedder, bladder, colorectal cancer, ovarian, breast, and pancreas. For moderate shedding tumors, that's defined as detectable in less than 75%, but often around or above 50% of patients, especially if it's a more localized cancer, such as breast cancer or pancreas or gastroesophageal cancers that are localized, might be considered more moderate shedders. And that's in contrast to colorectal cancer, even at a localized stage, tends to be a big shedder. And then low shedding tumors, where it's detectable in less than 50% of patients, even though these patients may have advanced cancer, brain tumors, kidney cancer, prostate cancer, and thyroid cancer. So how sensitive the cancer is, this test is to figuring out whether it has a lot of utility for that kind of cancer is now what kind of shedding, how much shedding, what stage the cancer is. Next slide. All right, where could MRD be informative? Next slide, please. I'm just going to give you some hypothetical examples where we could consider using MRD testing today. One is in patients with stage 2 colon cancer. Now, it's very common that if you're diagnosed with a stage 2 colon cancer, that it's resectable, that it's removable. That's part of being a stage 2 colon cancer. It's not stuck down to other feet, the body. And it's removed, and let's say 2 to 8 weeks later, we do the blood testing for MRD. We've got the cancer, we create the assay with the correct probes, and then we do blood drawing. Let us say that the patient is ctDNA negative. Now, most patients with stage 2 colon cancer do not get adjuvant chemotherapy. So this would give you reassurance that that decision, which is normally the course of events, is correct. However, let's say after resection, the ctDNA is positive. I would say as a physician or as a patient, I would say, we need to do something. This cancer is going to come back. So that in that case, we're much more likely to consider adjuvant chemotherapy. And then after that adjuvant chemotherapy is done, monitor the person for response and how they're doing and make sure it stays negative. The next slide is an example of a stage 3 colon cancer where it's common for everybody to end up on adjuvant chemotherapy. But could you imagine a scenario for a stage 3 colon cancer where after surgery, the ctDNA is negative? And the physician may say, perhaps we could skip adjuvant chemotherapy, or I still feel uncomfortable with this new technology. I think we should do it, but we don't need to be as intense with the therapy. There are clinical trials ongoing to try to answer these questions so that we can make sure that this assay has high utility and that people have confidence in these decisions being made. Next slide. These are just similar thing. Now they've completed their postoperative chemotherapy and their ctDNA is negative. Okay, I have reassurance, I've done the right thing. Now I'll be monitored over time for my response. Or their ctDNA positive after their adjuvant chemotherapy. I think as an oncologist, I'd be like, there's something more we need to do. I want to make sure that's a real positive. So let's repeat it in a month or 3 months. Let's do scans to see if we can find evidence of cancer. But I think it would change not only what I do in terms of therapies potentially, but how I monitor the person afterwards. Next slide. And we have a couple of examples around breast cancer. So breast cancer, we've said it matters how well it sheds. It's a pretty good shedder, but it depends on the stage of the
Christy,
cancer.
can I interrupt you for a second and just ask for some clarity around why breast cancer is both a medium shedder? Can you just describe that a little bit for the audience, please?
So it's actually not all of the subtypes are median shedders. And that's the portion of this slide, which is it depends upon what biomicrotype the breast cancer is. So triple negative breast cancers are much better shedders than estrogen receptor positive, HER2 negative breast cancers, and HER2 positive breast cancers are somewhere in between. So now it's not only breast cancer is a moderate shedder, now it actually says what kind of breast cancer is it, and then what stage it is. So we think especially for hormone receptor positive, HER2 negative breast cancers, that eventually we will find that the much more sensitive assays may be the better way to go in order to do MRD testing. And that would likely end up being assays with very low limit of detection, whether it's the current assays, which are whole exome, or more extensive assays that are called whole genome assays. Next slide, please. Thanks, Tawanna, for that question. So just an overview of this test, because I've gone on and on. The Oncodetect test is a personalized tumor-informed MRD, molecular residual disease assay, as I said, based on this person's cancer, nobody else's cancer. It measures cancer detectable in blood through circulating tumor DNA. It informs on the risk of cancer recurrence and may help guide treatment decisions. And it can detect recurrence earlier than traditional imaging methods like CAT scans, X-rays. The Oncodetect test uses each patient's unique tumor profile to find evidence of that circulating tumor DNA or their cancer in the blood, and it detects and measures MRD, giving insight into future decision-making and therapies. The main feature of our current Oncodetect test, it uses the patient's tumor tissue to create a custom-made blood test. It monitors up to 200 mutations in the patient's cancer, and then uses machine learning and AI to produce results indicating whether it's a positive ctDNA or negative ctDNA. And then last slide, I believe. What information is MRD testing poised to offer patients? Do I still have cancer after it's been removed surgically? Do I need additional therapy or a different imaging surveillance strategy over time? Did my cancer respond to therapy? Or is it responding right now? Do I have molecular evidence of cancer persistence or evidence of a recurrence of my original cancer? Next slide. And then just solutions before, during, after cancer. Getting back to one of our original slides is all of the products that Exact Sciences has in order to help guide patients through their decision making, perhaps by adding a couple of these tests together to further personalize the recommended care for patients before, during, and after a cancer diagnosis. That likely, thank you. This is my last slide. Okay. Thank you, Stephanie and Tawanna.
Thank you so much, Christy. I am delighted, Stephanie or Leah, if you could unmute Trevor, that would be great. I'm delighted to introduce Trevor Maxwell, who is the founder of Man Up to Cancer. He's also a stage 4 CRC survivor. You know, at Exact Sciences, we recognize that cancer is not just a diagnosis story, and it's not just about the data that helps provide these solutions that Christy was just alluding to in her fantastic overview of Oncodetect, but it really is about what are the implications for care. You know, what's the patient story and what's the lived experience behind that? And Trevor is here to share a little bit about that with us today, his experience with MRD testing for the past, Trevor, you'll have to clarify for me, 4 or 5 years, but we'd love for you to have the opportunity to share with the audience that the personal side of what a test like Oncodetect can do.
Yeah, absolutely. Thanks for having me. Some technological glitches, but in the world of cancer, that's small potatoes. But I will say this. I kind of missed out on most of Dr. Russell's presentation. So look, I am a patient, right? So, but if I say anything that contradicts what she said, hers is the control. So, just
Thanks
understand
for the
that.
level set.
Yeah, so thanks for having me again. I'm Trevor Maxwell. I live in Cape Elizabeth, Maine, and I've been living with stage 4 colon cancer since March of 2018, so about 7.5 years. And I've been using MRD testing as one of the top 3 tools in my toolbox for managing my disease for several years. And I'll get into what those tools are in a minute. But just to put a human face on this and really center us on what we're all trying to get to and talk about is um, I was diagnosed at 41. I'm a Lynch syndrome patient. No early onset in my family. It was like a life asteroid for us. Certainly did not see it coming and didn't even know what Lynch syndrome was before I got diagnosed. After my diagnosis, and I just wanted to say that our daughters, so we have 2 amazing daughters, my wife and I here in Maine, they were 12 and 10 years old when I was diagnosed with cancer. And the prognosis looked really bleak, right? I didn't know if I was even going to make it to get them into high school. And I'm so grateful and blessed to let all of you know that our daughters are now 20 and 18, and they are both college students. And this is centering us because this is all the work. This is the work that we're doing is we are trying to get more people like me who can either be cured or like me manage it as a chronic illness over a long period of time, which would not have been possible before a lot of these new tools, whether it be immunotherapy, MRD, surgical advances. So I'm a very lucky guy. Um, so I've been in treatment or having surgeries most of the past 7.5 years. My cancer started in my colon on the right side, spread to my liver, strangely the tail of my pancreas. So I ended up having a distal pancreatectomy throughout my peritoneum, so the lining of the abdomen. Um, I've been through 7 major abdominal surgeries and more than 75 rounds of chemotherapy, immunotherapy. So it's been, I've been in the trenches, but I'm very lucky to be MSI high colon cancer and have a really good response to immunotherapy, especially. Wouldn't be here without it. So the top 3 tools that I use to monitor my cancer over this long haul are scans, so CT and MRI, MRD, and CEA, which for those of you who might not be familiar with it, CEA is basically a protein in the blood that's often elevated in different types of cancers, particularly colon cancer. But here's the thing about CEA is that it's not accurate. It shows the level of cancer activity for a lot of us, and mine has been very reliable and very accurate. But I think for 30 to 40% of colon cancer patients, it's not accurate. So it's not a very reliable test. Um, so those are the 3 tools: scans, MRD, and CEA. And so I live here in Maine. I get my local treatment at New England Cancer Specialists, but I've done surgeries and consults at Mass General, Yale, and I've done a clinical trial at Johns Hopkins. And all of those teams, I think I was one of the earlier adopters of MRD in the colorectal cancer space several years ago. And all of those teams at Yale, MGH, here locally, at Johns Hopkins have incorporated MRD into managing patients like me. So I can just tell you, like from the patient perspective, from the clinic perspective, when I have consults with my teams, one of the first things we're going to talk about is my MRD because we've been measuring it on a serial basis for a long time, and it's been super accurate. So that's one of the first conversations we have. Um, I've used MRD as a stage 4 patient in a variety of settings. So response to immunotherapy, response to the clinical trial that I did, response to chemotherapy, and then also for pre and post surgery testing, having that baseline before surgery, seeing if it's positive or negative after surgery, and then also just in surveillance. So when we're kind of in watch and wait mode, we are tracking and using those 3 tools. So overall, I would say MRD has been super empowering for me. It's always tracked reliably with my CEA and with my scans. And when it's positive and rising, I know that my team and we need to be vigilant. We need to be talking about scanning and maybe even pushing up scans. We need to be, one thing that we always talked about in colon town and different colon cancer communities is having planes on the runway, meaning you might be on one regimen now, but you need to be always looking at what are those next planes you might be hopping on? What are the planes on the runway that you might go to next? And so when you have a positive MRD, you're proactive about talking about that and making sure you have a game plan. That really, for me, has kept me in a proactive position. I want to be proactive about my cancer. If there's tests out there that can show me real-time data about cancer activity, I want to know that so that I can plan accordingly and really understand what's going on. I don't want to be in a reactive situation where I'm not looking at my blood, I'm not paying attention to it, then all of a sudden we have, a growing metastasis that we weren't aware of. So when it's positive, you're proactive. When it's negative or falling, I'm really confident that there's very low or zero cause for, or zero, I'm sorry, very low or zero cancer activity. And that is a cause for celebration always. I'll give you one particular memory, kind of on the emotional side of this, is that all my surgeries kind of blend together at this point. But after one surgery, it was the fall, and we were headed into the winter after a big surgery, and we were waiting for my post-surgery MRD test result. And it was like early December, and we were walking around the old port in Portland. It was me and my wife and our daughters. And I actually got my result in. I checked, and it was MRD negative. And it was just such a relief and a celebration, because we knew going into Christmas that based on that and in concert with those other factors that we look at, I could be confident that my cancer was pretty much either dormant or basically close to dormant at that point. Another example, I was on surveillance, watch and wait for much of 2024. In the second half of the year, my CEA and MRD started to slowly tick upward. And I've been super lucky because even though I don't have a lot of cancer burden, my cancer is shedding and it is being detected by MRD. So the levels that I was seeing with CEA and MRD creeping up were not large, but they were consistent and they were both tracking upward. And I knew at that point that, there was something going on, trending in the direction of progression. And so we talked about it with our team. We didn't make any decisions at that point, but we knew that we were going to be scanning vigilantly. And when we scanned in January of this year, we did see that interval growth of a couple tumors in my abdomen, still small tumors, like 3 centimeters or under. And that's when I went back on immunotherapy. And we did not know what response I was going to get. I was essentially re-challenging immunotherapy that I had progressed on maybe 3-4 years ago. And when we went back on immunotherapy, I've been doing MRD testing and CEA testing at, I forget exactly what the intervals are, but they plummeted. Right when I started Yervoy and Opdivo, those levels plummeted back to, my CEA is basically historically low for me, and my MRD has been negative 4 tests in a row. That has been huge for us to show. I mean, that's a great real-time example of seeing the MRD test in real time, showing what a response can look like. I got a couple other notes here.
Trevor, can I interrupt
Yeah.
you for just for a second? I want to ask both you and then Christy from an oncologist perspective. Can you talk to me about MRD and de-escalation? So Trevor, what does that mean for you as a patient, and does MRD play a role in that? And then Christy, from an oncologist perspective, what are some ways that de-escalation might be prescribed for a patient utilizing these MRD results?
Yeah, real quick for me, de-escalation has been a factor in terms of, we are managing this as a chronic disease over many, many years. So we don't want to overtreat when we don't need to. So we will look at the MRD, and if it's negative in concert with my scans and CEA, then, we know that we're not looking at treatment. But I can also just tell you that I have a lot of other friends in this space, and de-escalation to me means this. If you have a surgery that has curative intent and you go into that surgery, and let's say you're a stage 3 colon cancer patient and you come out of it and you get that, maybe you get those 2 negative MRD tests in a row, and your team decides that you can avoid mop-up chemo. That is, I can't even tell you how massive that is, because chemotherapy is suffering. I've been on the kitchen sink chemo. It is agony. It is suffering for the patient. It's suffering for the family. And it also comes with sometimes lifelong side effects that really hurt a person's quality of life. So sometimes it might be easy for people to say, let's just treat, let's just give more chemo, let's treat it. But if you don't have to, if you can de-escalate and not treat it, that makes a huge difference for a family and for a patient. And I'll turn it over to Dr. Russell.
I think well said, Trevor. You're living with this cancer and this assay. I think the greatest potential promise is to avoid adjuvant therapies where they're not necessary. And we give a lot of adjuvant therapy, and we do it based on very crude measures of tumor size and lymph node involvement, et cetera. But even knowing that information, all we know is a risk. You have a 30% risk that cancer is going to come back, or a 60% risk. And MRD has the promise to get that number much more specific for the patient. I would say a negative MRD, because of the technological issues with MRD, will always say there's 0 chance this cancer could come back. But we could get it better than a 30% or a 60% chance. We could get it closer to 100% chance and closer to 0% chance, depending upon the assay and the kind of cancer. And then, we could really hold off on unnecessary therapies, or until we're able to really back down on these therapies completely, perhaps not throw everything up, against the wall and give every therapy we always give. Maybe 4 cycles of adjuvant therapy, not 6, or cut out one of the more toxic drugs, et cetera. So I think the promise is to change the adjuvant therapy to a lesser regimen, or maybe eventually to cut it out completely.
Thank you. Trevor, if you could just clarify with us, have you largely been seen at academic centers? Because there's been a thought process or a question that sometimes MRD, molecular residual disease, it still feels very new, particularly in community health setting. And so if there are patients that have asked for it and been told no, or, are not seen at an academic center, how do they explore that no if it's something that they're considering pursuing? Clear that this is just your opinion on the matter.
Yes, my opinion. So I started out with MRD in the community setting because I learned about it from other patients, other peers. And I took it to my clinic and I said, hey, there's lots of buzz around this. Like, are you using MRD? Can we consider it? And my local practice was like, we haven't used it, but we're going to learn about it. And they did. And I think I was the first person there to use it. And now it's used throughout the clinic. And I know that not all clinics will be that receptive. I was very fortunate, but for those who, let's say, most people are being treated at community, right, centers rather than NCI centers. And I would say start with your clinic and say, hey, like, I've had these conversations with Exact Sciences. I've heard from Trevor Maxwell, another patient, all these other patients. We were talking about MRD. Is there a place for that to be considered in the management of my disease? And it just, and whatever information you can bring, I know Exact has some information that you can bring to talk to your team about, and just say, is this something we can learn about together and have a conversation about? If you get a hard pass or just a no from your clinic, then it's time to maybe start bringing in someone else who's used it to talk about it, or reaching out to Exact and asking for more guidance. But at the end of the day, it's patient choice. We are the patients. It's our blood. It's our body. It's our disease. And I will fight for that. I will fight for other patients to be able to access this technology, because we have the right to have this data. Again, it's a test that is incredibly valuable when measured serially over time. And so, I mean, to go to extremes, sometimes if your team will not do this for you, sometimes you might have to ask to get a second opinion and talk to someone who will.
Tawanna, I put a lot
You're
of
on mute.
answers into the chat.
There you are, and I was going to ask you some of those questions, so thank you very
Well,
much. I
Well,
appreciate
you're
it.
welcome to repeat them. I don't know if people are looking at the questions.
Let's see, we'll start with one that I've heard a fair amount. And so, Christy, when you talk about colon cancer, does that include rectal cancer? And can you please advise?
Yes, so my error, I should have been saying colorectal cancer. In the beginning, the decisions are very different about how to treat a rectal cancer versus a colon cancer. So depending upon how early the cancer is found, it's more common that in colon cancer it's resected. In rectal cancer, the patient potentially could go to neoadjuvant therapy or giving chemotherapy and radiation therapy up front before the patient goes to surgery. Although the question is, do they all then need surgery? And is there a possibility you could use the MRD test to decide whether that therapy has eradicated the cancer and they don't even need to go to a surgery? So it's just a different way of treating those cancers up front that could affect when the MRD test would be used. The other thing is, Tawanna and Trevor, that when we usually do this testing, we usually have a lot of cancer. The cancer's been resected. We use that cancer to create the assay. If you're in a situation like rectal cancer where we want to give some therapy up front, you're dealing with a core biopsy or much less cancer to do the testing. And so there are always limits of any test. You have to give enough cancer over to the lab in order to do the different tests of the different genes in the cancer. So there's the potential that in a rectal cancer, not enough cancer has been sent through to our lab to actually be able to do the baseline testing. Although we inform the physician rapidly as to whether there's enough cancer there and they may need to provide us a different specimen or more cancer for us to successfully create the assay for that patient.
Great, thank you. Another common one that pops up that we've heard before, Christy, is the distinction between minimal residual disease and molecular residual disease terminology. Can you expand upon that a little bit?
Sure. So minimal residual disease is where it first came from, commonly used in leukemias or blood cancers. Multiple myeloma is a great example, where we know the specific genetic abnormalities of that cancer, but it's a blood cancer. So they're always doing blood tests to go find evidence of whether that cancer has been cured with that therapy. Molecular residual disease is in solid tumors that started in one of our organs, not a tumor that started from the bone marrow or the blood products. People use it interchangeably, and even brilliant people in this space will sometimes say minimal, but they don't really mean that. They mean
if Oncodetect uses patients' unique tumor profile at a certain time point, how does the test account for tumor evolution over time?
So it does not. And we need different testing to see whether that person's cancer has changed. So let's say a person has a new cancer that's popping up on an X-ray. We have a positive MRD and we do a scan and we find something. Well, you have two things that you could do. One is that you could get a new biopsy of what you could see actually whether it's the same cancer as the original cancer or whether we're finding a brand new cancer. Or you could do a liquid biopsy or a liquid test and then do comprehensive genomic profiling on the DNA that is circulating in the blood to completely resequence and look at every genetic abnormality in that cancer to see if a new one has popped up for which there's a targeted therapy available. But when a person goes from normal, I'll use colon cancer, colorectal cancer in this circumstance. When you go through the process of having normal lining of the colon to a polyp, to a precancerous polyp, to frank cancer, there are genetic variants or abnormalities that are accumulating in the lining cells of the colon. And it is the compilation of these genetic abnormalities that allow a normal cell or a normal colon line to go from normal to polyp to precancerous polyp to cancer. Those genetic abnormalities will always be there. We call them founder mutations. They will always be there. And we can always go look for them in blood with MRD to see if they're still there. Now, let's say somebody has 170 variants, was my example. And let's say over time, the cancer, we're not looking for 170 variants and say, if you don't have 170, we're going to call it negative. We use machine learning and an algorithm to say, maybe we only find 40 of those 170 variants, but we'll still call that a positive because it's not coming from our normal cells. It's coming from the cancer. So if there are new genetic abnormalities that have popped up, we won't see that because we'll only have the probe set for the original 170. A different test would need to be done if there's evidence that the cancers come back and we have a positive MRD. You can either do a completely different test, a liquid biopsy. We have one in production. We will be calling it OncoLiquid. Or you could biopsy that tumor tissue and send it for comprehensive genomic profiling, and then look again across all of the genes to see if there are new targets for which there's a therapy available. So Trevor, you've kind of probably had both. When they were in there and had you open with your surgeries, they were probably taking specimens of the cancer, retesting to see whether there are new variants. But your MRD test is not going to ever be based on those new variants. It's going to be based on the original ones that were in your cancer.
Yeah, I'm kind of a little bit of a unique case because they used, I had some solid tumors in my liver that were used to inform my MRD. But the metastases out in the peritoneum have been cystic, mostly mucin. So we have not been able to get a reliable tissue biopsy from any of those. It's just too much mucin, not enough cancer cells. But that hasn't prevented the test from working for me, even without a rebiopsy. So I don't know the science behind that, but I'm still shedding and it's still working. But if I could touch on one more thing, Tawanna.
Yeah, absolutely.
One of the things we hear from patients a lot in terms of criticisms, or when local teams are not comfortable using MRD, a lot of what the patients are hearing is, we don't know what to do with this information. We don't think this is actionable. What do we take this test, whether it's before or after surgery, and we get a positive or a negative? Like, we just don't have the guidelines or enough information right now to dictate what we should do. And, as a layman and a patient, I would just respond by saying first of all, the same thing could be said for CEA. Any type of solitary test where you just test once and you get a result generally isn't going to be actionable in the cancer space. What we're looking for is trends over time. And I always tell people that just because an MRD test might not be actionable one time in the moment doesn't mean it's not valuable over time. That's where the value comes in, where you can track it over time and watch it. And that's how the test is meant to be used, is serially. And I think seeing the NCI centers and top centers adopt this into what they do on the ground shows you how powerful the technology is and how credible it is. Even in advance of some of the regulatory process, which can take a long, long time, and patients don't have a long, long time. Yeah. So I'll leave it at that.
Yeah, that was powerful. Thank you, Trevor. Christy, if a tumor isn't a good shedder and gets a negative test, is it possible that something could still be there?
Yeah, I'm answering that question right now. So, yes, a negative is not 100%. You could have cancer in your body and you could have a negative. Trevor's probably had a negative ctDNA tests, but he still has cancer in his body. He probably has a lot less cancer in his body than when he turns positive. But you will never know as an individual whether your test is sensitive enough if the shedding is very low. And We just know in general. So I'd say breast cancers could be a medium shedder, but you won't know as an individual whether your cancer is a good shedder or not. So when I made that comment about shedders, this is just very generalized, but it is not specific to a person and their situation. It's just generalized for those disease types. And the reason why I made the point is there are kinds of MRD tests which are called whole exome. They are less sensitive than whole genome tests are, but whole genome tests are just now coming on the market. They are more expensive. Private insurances pays little to none for any of these tests. And so there's an economics question about when to use a whole genome assay versus a whole exome assay. I think the technology and the cost and everything will improve enough over time that, as we know, for all genomic testing, it gets cheaper and cheaper. But right now we're creating an expensive test, but we'll always want to use the most sensitive test, the one that's going to perform the best, even in low shedders, so that people can have greater confidence that a negative is a negative. But as with anything, you can have an X-ray and it's negative and you still have cancer in your body. So, every technology has its limits, but a massive amount of effort is being undertaken to get this test to its most sensitive. So we have our Oncodetect, which is on the market next year, mid 2026. We'll have our whole genome assay. It'll be more sensitive than our current assay, and this technology continues to improve over time.
Christy, should we be thinking about MRD testing for breast cancer patients on tamoxifen for 5 or 10 years? Would it help in cutting the number of years that drug is needed? Yeah.
There's actually a study that's been published on this a couple of years ago, and it was looking at whether women were positive at that 5-year point of their endocrine therapy, and whether it was a retrospective study. So all the decisions that had already been made about women should get 5 versus 10 years of their hormone blocking therapy. But the test that was used for that study was very helpful in understanding that if at the 5-year point you are negative, the likelihood of relapsing after that was quite low. So I'm not saying it's standard of care yet, but I think we will get there to understand what to do at the 5-year point for patients on a hormone therapy for the breast cancer. And maybe we'll get there at the 3-year point or the 2-year point, or, that we'll have a better understanding of saying it can only be 5 versus 10 and nothing in between.
Why were lung cancer types not included in this analysis,
Christy? Well, I answered that. So these are just examples. I think every solid tumor has the ability to shed and for an MRD test to work. And it doesn't matter what organ it came from. It really has to do with getting, some of that tumor, letting us test it, letting an assay with probes be made, and then it'll be sensitive for that person's cancer. So we had some lung cancer slides in here, which I removed. I wasn't going to create a slide for, hundreds of different types of cancers.
Gonna do a
I like one that says, Trevor, you are an amazing speaker.
Yeah. As he is.
Thank you. The check is in the mail.
We've got a question about insurance and coverage for MRD testing and Oncodetect in particular. Christy, can you share?
As each therapy is found to be validated, that when you get the test done, it'll read the same each time if you test it over and over again with the same specimen. And there's what's called analytic validation and clinical validation. Once you have this validation, you can take your test to Medicare and ask to get it Medicare approved. But having Medicare approval does not guarantee that you have Medicaid approval, and it certainly doesn't make the private insurers begin to cover this testing. And so they have a different level of evidence that they're looking for before they will cover this testing. And some of those levels of evidence are that we show what's called clinical utility, that using the test will, for a general cancer population, alter a decision that the doctor would have made or recommended regardless, and then that decision influences the eventual outcome of that patient. So, for example, if I decelerate patients who have a negative MRD, we are trying to prove through clinical trials that that was the right decision, and that the same percentage of patients, that you didn't see more recurrences on those that you decelerated based on MRD versus not. There are really literally hundreds and hundreds and hundreds of clinical trials ongoing in many, many different cancer types to find that utility, to prove using MRD will not only affect the decision that's being made eventually, but could have an impact on your eventual risk of recurrence and eventual survivorship from cancer. And until those trials are completed and show that, most private and most guideline committees like ASCO and NCCN will not recommend using MRD, and thus private insurance, for the most part, won't cover it. So we have Medicare coverage currently for stage 2, 3, and resectable stage 4 colon cancer. And we have all of our studies ongoing in breast cancer, and early in 2026 will apply to Medicare for coverage for breast cancer, but it's one cancer at a time, according to Medicare.
Trevor, from a patient perspective, and also as a founder perspective, can you share any advice or steps you would give any of the patients and caregivers that you serve when a test isn't covered by insurance, or if they're having an opportunity with access or the finances that guarantee that access?
Boy, I don't know if I'm the right person to answer that. I mean, I think companies like Exact Sciences are doing a great job trying to make it available as much as possible at a low cost to patients, pending that kind of widespread approval. So just keep talking to the company and ask them. I think probably you're in a better position to give advice on that. And I'll just leave it at that. I really don't have any particular insights.
We have reached almost our time limit, and unless we receive another question within the next minute or two, I think that we are all set. Christy, Dr. Russell, we're so grateful for your overview of molecular residual disease and your succinct but thorough answers to the questions. And Trevor, while you may be a seasoned advocate, sharing of yourself and of your story is not taken for granted. We greatly appreciate you pouring into what it looks like to have MRD in your toolbox, because that's what it is, right? And so at Exact Sciences, as Christy, has said, we're doing shameless plugs, right? Because we are Exact Sciences and we believe in it, but we've got these solutions across the board, and MRD is just one of them. There are tools wherever you're at, particularly in colorectal cancer, but across the cancer, experience that an individual may have. And we recognize that we don't get to true solutions without incorporating voices like yours, Trevor, and without opening it up into, webinars and getting the patient advocate and patient's voice and opinion as well. So we want to thank everyone for tuning in. Thank you, Trevor, for your story. Thank you, my team, for helping and supporting as always. And we wish everyone a wonderful day. You have all of our personal information if you need to reach out to us. And if not, you can find us on LinkedIn. We're all there. We look forward to answering your questions. Have a great day, everyone. Thank you.
Thank you.
Thank you.